to, particularly in IG vasculitis, where just hemorrhage would have made us think of just IG nephropathy, but the fact that there was skin, joint, GI hemorrhage uh, helped us think of IG vasculitis in this case.
Okay. Dr. Dawn, you'd like to come in now? Any questions you have for the registrar and the intern, something that you may have supervised or asked them to read up about? Start off with that, and then you can compliment, and then you can give your your comments.
I actually Nikita came to me and asked me if I can, if she can present the this gentleman's presentation as a cutaneous and as a systemic vasculitic syndrome. I thought at an intern level, a basic understanding of how a vasculitic syndrome presents and what are the broad vasculitic syndromes and the various ways large, small, medium vessel vasculitis presence. A basic understanding of that will be a helpful thing, and I think if she can remember that patient's cutaneous manifestations, and that she'll be able to pick up uh, uh, cutaneous vasculitic manifestations in future and approach a case, approach a similar vasculitic patient in the future. I think she did a presentation quite well. Yeah.
Thank you, Don. Any questions from anyone?
Nikita, I just request you to post your presentation in the Teams folder, and it will be good if in future all the registrars post their presentation before the talk, because that way people can view it in case there's a break in connectivity. And I'll set up a folder for each month, so that way when you label your presentation, also please label it with the name of the presentation followed by your name, so we can always go back to it and reorganize it later. Thanks.
Okay, sure, sir.
Thank you, Tarun. I think that's a very important suggestion. We should have a folder of all the presentations done. I think Tarun has organized it well. So we make sure that all the PGs goes there. Any other comments or suggestions? Any other comments? Okay, what I would say, Nikita, I think you started off well. You have taken up a case, and I think that makes the presentation relevant to the cases that we see. So that was well done. One thing you could have added on your learning objectives at the beginning of your presentation. I mean, just make it a habit, so that what that does is it makes you clear, because vasculitis itself can be a huge topic, as much as the topic that you said was approach to vasculitis. I mean, you could list down the learning objectives. It could be more than just one point, so that will help you to stay focused on what are the specific things in vasculitis you are attempting to present, given the nature that vasculitis is a very broad topic. So that is one thing. I think the rest of the presentations, in terms of classifications, approaches to each one of them at your level, was done quite well. One more thing is generally, not just for you, but for all our PGs also, that we are finally looking at a clinical translation of this information. Say, for example, if now you had this specific patient and you read about this patient, and that would have helped you in understanding about this patient and the diagnosis, and also generally about the broad classification of vasculitis in general. What would be helpful is, how do I approach a patient? So the next approach is from the clinical perspective. If a patient, in which patient should I suspect vasculitis, and how do I classify or approach the vasculitis based on the classifications that you have laid on from a clinical perspective. Should I do all the tests for all patients where you suspect vasculitis? That will be too expensive. So how can I make an algorithm, a clinical algorithm, to say that in this patient I suspect small vessel, in this patient I would suspect medium vessel, in this patient this is most likely a large vessel, and so based on that, how would I put my investigations in a flow diagram? That will be something that will be helpful for any of our doctors to be able to approach a patients where you are suspecting vasculitis. So question number one is, when do I suspect vasculitis? What's the clinical setting? And second is, how do I approach clinically that patients with vasculitis, which means what history, what examinations would help me to differentiate a small from a medium to a large, and then based on that, in which group, what investigations will I do it, so that it becomes very streamlined and much more focused on your investigations and your diagnosis, and then finally the treatment would follow based on that, right? So that is something that could have been done. It depends on, I mean, it's a little bigger exercise, whether at your level you are able to do it, but that's something that can be expected from a PG level, and that's something that I would expect Joel, as he supervises that case, should be able to also come up with. So that's the clinical approach. So that finally, when you open books on these topics, you see volumes of things written down. How to organize it in a most simplistic way on a bedside is what we want you all to develop over a period of time. But otherwise, for your level, I think you did a very good presentation, and I'm sure the reading and the presentations would have helped you in an understanding about vasculitis in general and the different types of vasculitis and their presentations. If anybody has anything else to add on, kindly do it before we go to our next presentation. And Dawn has posted some evaluation performer. I would encourage all the faculties to fill it up, give specific comments that will be helpful for them to keep improving their presentations with every sessions.
To all faculty who is attending this session, I have posted the evaluation form in the Medicine for Faculty group. If you open it, you'll be able to mark your responses. Thank you.
If there are no further comments, we'll go to Joel's presentation.
Joel, we can see your slide. Go ahead.
Title is The Effect of Fear on Chronic Kidney Disease.
Can you see his slides? I can't see the slide.
It was seen, now it's gone. Joel, can you set it up again?
Can you hear me?
Yeah, we can hear you.
Okay.
Yeah,
The
now
slides
it's
come-
now it's
okay.
come.
Okay.
Go ahead.
Go ahead.
Okay, this journal is called The Effect of Finerenone on Chronic Kidney Disease Outcomes in Type 2 Diabetes. It was published in the New England Journal of Medicine the first week of December. Background. Finerenone is a drug which is a non-steroidal selective mineralocorticoid receptor antagonist. Its functions studied are it helps to reduce albuminuria in patients with CKD and type 2 diabetes, and also it has long-term effects on renal and cardiovascular system outcomes. We know mineralocorticoid receptor antagonists such as spironolactone, which is steroidal and is non-selective. We know eplerenone as non-steroidal and selective. Finerenone is another drug which is non-steroidal and selective action against the mineralocorticoid receptors.
I mean, you could.
There's evidence that supports a physiological role for overactivation of the mineralocorticoid receptors in cardiorenal diseases, including CKD and diabetes, through inflammation and fibrosis that leads to progressive kidney and cardiovascular function. So we know for individuals with diabetes that go into chronic kidney disease, the management would be to slow down the progression of CKD by controlling diabetes, controlling hypertension, using ACE or ARBs to reduce albuminuria. So they try, but then still we see this progression of CKD nevertheless. So the study aims to look for newer drugs that can help to slow down this progression of CKD. One such receptor that is used is mineralocorticoid receptors, and the drug studied is finerenone. We generally don't use spironolactone because of its side effects of hyperkalemia, gynecomastia. Though it helps to reduce albuminuria, we generally don't tend to use it along in patients with CKD. But finerenone is one drug that has been studied in this article. Now, the Picard statement: population or adult diabetic patients with CKD. Finerenone was a drug used, and the control arm is placebo. Outcome was a composite of renal functions, which I'll be explaining for the first slides, and a median time period of 2.6 years was the time it took to do the study. The setting explicitly described, yes. The study was called finerenone in reducing kidney failure and disease progression in diabetic kidney disease. It was a phase 3 randomized, double-blind, placebo-controlled, multi-center clinical trial across different countries in different continents. And the pharmaceutical company Bayer, which was the one that which studied finerenone, and they are the ones that did the study as well. They conduct the analysis, but also they gave the authors all access to the data and participated in the interpretation of the data. Was the study population clearly defined? Yes. The inclusion criteria is all adults, which includes people more than 18 years of age, with type 2 diabetes and CKD, who are treated with ACE inhibitor or ARB at the maximum dose, which I'll be explaining, and people who had values of potassium less than or equal to 4.8. Now, how do they define CKD? It is one of the two sets of criteria. If individuals had albumin to creatinine ratio between 30 and 300, with an eGFR between 25 to 60 ml per minute, and diabetic retinopathy. However, if they didn't have diabetic retinopathy, they should have had albumin creatinine ratio between 300 to 5000 and GFR between 25 to 75 ml per minute per 1.73 meter square. We generally know the diagnosis of CKD should be less than 60 eGFR. Here, if the albumin ratio is as high as 300 to 5000, they accepted up to 75 eGFR for considering as a diagnosis of CKD in the study. Exclusion criteria is anybody who had kidney disease not attributed to diabetes, with HbA1c more than 12%, chronic heart failure with reduced ejection fraction, people who had stroke, a TIA or acute coronary syndrome the last 30 days prior to screening, people who are already on dialysis for an AKI at least 12 weeks prior to the run-in visit, or people with CLD with Child-Pugh C. So we can see that two uncontrolled diabetic patients, people who had heart failure already in reduced ejection fraction, were not included in the study, though one of the objectives was to look into cardiovascular outcomes, cardiorenal outcomes, severely uncontrolled diabetic and people who have already had the reduced ejection fraction in their hearts were not included in the study, which I think reduces the generalizability of the study. Control intervention clearly defined? Yes. Trial procedures. So there was a run-in screening and a double-blind treatment periods. Initially in the run-in period, everybody would be screened. Their background medical therapies would be adjusted, meaning if they had diabetes, if they had hypertension, they would be first controlled, and they would also be given ACE or ARB to a maximum labeled dose that did not cause unacceptable side effects. So apart from the mineralocorticoid receptor action, every other possible therapy was given the maximum treatment, so as to study what extra could this Fineron provide. So diabetes would be controlled to the maximum, the hypertension would be controlled to the maximum, and ACE or ARB to the maximum doses, provided there were no side effects. In the study, Fineron or placebo was withheld if the potassium went more than 5.5, and it could be restarted when the potassium levels came down from 5 millimoles per liter or less. Outcome measures were clearly defined. The primary outcome was a composite outcome of kidney failure, which is explained as eGFR less than 15 ml, and a sustained decrease of at least 40% in the eGFR from baseline over a period of at least 4 weeks, and death from renal causes. So this is a composite primary outcome. Secondary outcomes, which also studied, were the composite of, again, a composite outcome was studied in the secondary. Composite of death from cardiovascular causes, non-fatal myocardial infarction, non-fatal stroke, or hospitalization for heart failure. Also, they studied death from any cause, hospitalization from any cause, and also change in the albumin-creat ratio from baseline to month 4. The second composite outcome studied was the composite of kidney failure, a sustained decrease of at least 57% eGFR from baseline, maintained for at least 4 weeks, and death from renal causes. Were randomized, which is double-blinded, 1:1 ratio, computer allocated randomization. Randomization was concealed, yes. To what extent was the study blinded? It was a double-blinded study. Looking into the baseline characteristics. Here you can see this Fineron group, this placebo, and the total group. Age, almost everybody was beyond 65 years, plus or minus 8. Predominantly male patients. You can see in terms of race, it's predominantly white individuals who are recruited in the study. About 62% of patients. Some Asians included, which is about 25%, but not a lot of blacks were represented in the study. In the Asian centers, Japan, Malaysia were included, but India wasn't included in the study. Duration of diabetes, about 16 years plus or minus 8. So you can see long-term diabetic patients have already gone into chronic kidney disease. So after the run-in period is where they get randomized. So within the run-in period, the glycated hemoglobin has come up to 7.7, which is decent control for somebody with decent control. But again, we can't interpret the HbA1c values when somebody with CKD. Blood pressure is also systolic 138 across the two groups, which is again well controlled for patient CKD, which is less than 140. Looking to the eGFR, people had a mean eGFR of 44, which comes under CKD stage 3B. But you can see predominantly 50% of patients had eGFR between 25 and 45, which is about which is further into the course of the chronic kidney disease. Just 11% of patients had more than 60 ml per minute, which doesn't classify as CKD. Less than 25 ml, which is not end-stage kidney disease yet, but 3C and further. 3B and stage 4 would be about 2.3% patients. Between 833 and 867, which suggests there is about stage A3, which is significant albuminuria. About 87 patient potassium values were 4.3 across 3 groups prior to giving them Fineron. For the baseline medications, 60% of patients were given ACE and ARBs, but they were not mentioned. We really don't know. 58% got diuretics. Statins, about 74% of patients receive statins. Potassium lowering agents would be other drugs such as K-bines, the racins, and the caxlates. About just a few percent of patients received it. Important thing here, T2 inhibitors in the glucose lowering therapy. We have seen multiple trials in the last year that have come and shown that glifosins had important action in reducing the rate of progression of CKD. So you can see here about 4.4% and 4.8% were already on SGLT2 inhibitors. We don't know. Were an adequate number of people included in the study? Yes. The study had calculated a power of 90% so as to achieve 20% lower risk of a primary outcome event with finerenone compared to placebo, and for which they would have they should have at least 1,068 patients with a primary outcome event. It was a time to event analysis. So when 1,068 there should be at least 1,068 patients who should have achieved the primary outcome to show a 90% power in achieving 20% decrease in outcomes in finerenone when compared to placebo. Alpha value is also 5%. Consort diagram. So initially 13,000 people underwent screening, of which only 5,734 underwent randomization at the end of the among the 734, 2,866 were randomized to finerenone and 2,860 were randomized to 1:1 randomization. From there, we can see that about 822 discontinued the trial regimen in the finerenone group and 801 discontinued trial regimen in the placebo group, which is about 28% of patients had to discontinue the trial regimen. The reasons are given is about 309 had an adverse event, 148 had finerenone discontinued by the physician, and 130 died, 150% withdrew. About similar numbers in the placebo arm as well. And find in the final analysis, about all patients, about 233 included in the finerenone group and 2,841 included in the placebo arm. So you can see not all included. Probably it's a modified intention treat analysis. Follow complete? Yes. The patients analyzed the group they were randomized? Yes. It was not stopped early. For the validity of the study, I thought the study population was well defined. Outcomes were also well defined, though it was all composite outcomes that were studied. It makes me think, were the outcome definitions altered once the results came in, because it's all composite outcomes? Randomization was adequate. One was done. It was a double-blinded study. Sample size calculation was adequate. Intention treat analysis was a modified intention treat analysis, and baseline characteristics were very well matched. Looking into the results, which is a combination of kidney failure, end-stage kidney disease, a decrease in EGFR less than 15 ml per minute. So end-stage kidney disease cause for it. The second is sustained decrease of more than 40% in EGFR from baseline, and last death renal causes. So it's a composite outcome. And we look at the composite results. About 17.8 patients in the finerenone group, which is about 504 from the 2,833, had an event in the follow-up period, whereas 21.1% patients, which is about 600 in the placebo group, developed the event in the follow-up period. And they don't mention the difference, but then they calculate the hazard ratio about 0.82 and the confidence interval going from 0.73 to 0.93. Which roughly translates to about 18% lesser chance for the patient finerenone group to develop a primary composite outcome, and the p-value is 0.001. But if you look into the individual findings, individual composites for end-stage kidney disease, and you can see the hazard ratio is 0.87, with the confidence interval slightly going above 1, which is a similar case for sustained GFR less than 15 ml per minute, which the hazard ratio is 0.82, confidence interval slightly crossing 1 to 1.01. But it did help in decreasing the values for value in GFR values for more than 40% from baseline, the confidence is seen to be significant because it goes from 0.70 to 0.92, hazard ratio 0.81. So I think predominantly, I think it's this composite that would have resulted in a statistically significant finding in the primary composite outcome, which is sustained decrease of more than 40% in the GFR from baseline. So now that the primary outcome has been established as favorable outcome for finerenone, looking at the key secondary composite outcomes, which is death from cardiovascular causes, non-fatal myocardial infarction, non-fatal stroke, and hospitalization for heart failure. Here we can see that similarly there is about 0.86 for the composite outcome. 0.86 is a hazard ratio, confidence interval ranging from 0.75 to 0.99 with a p-value 0.03 showing significant for the composite. For individual components, however, you can see that the confidence interval all have been going beyond 1. So we don't know, but the net outcome did show some significance, but we're not sure what it did. Mineralocorticoid receptor antagonists have a role in cardiovascular causes because it helps in prevent remodeling. But how it helps for non-fatal stroke, I wasn't able to understand. But mineralocorticoid receptors have a role in fibrosis and inflammation in the body. So probably that could probably play a role for non-fatal stroke, especially for heart failure also in terms of p-value. Favorable outcome. The composite showed 0.03, which statistically suggests that finerenone did have a role in the long-term outcomes in terms of cardiovascular outcomes. Death from any cause, the hazard ratio is 0.90, but the confidence interval went beyond 1, which is the case for hospitalization for any cause. When they looked at the composite kidney outcome, which is GFR more than 57 from baseline, it did show a favorable outcome, the hazard ratio being 0.68, ranging 0.58 to 0.82. Looking into some graphs with the similar findings, you can see for the timeline from 0 to 48 months, you can see there's a for the primary composite outcome. You can see it's from 12 months, which is about a year. You can see some difference in the two groups, placebo and finerenone, which also applies for decrease more than 40% EGFR from baseline when 12 months. So people about a year into taking finerenone started to show difference in compared to placebo in decreasing the rate of progression of the chronic kidney disease. Similarly for kidney failure and secondary composite outcomes, for kidney failure, the confidence interval went beyond 1.05, but you can see some change starting from the 12-month period. Similarly for secondary composite outcome, which is death from cardiovascular causes. Again, slightly more earlier, but again, approximately from 12 months, you can see a difference. Now, just looking into the absolute reduction number needed to treat. If you give finerenone, about 17.8% had an endpoint 21.1. The absolute risk reduction, which is the difference between the two, was about 3.3%, and the number needed to treat was calculated to be 30. So 30 individuals needed to be treated with finerenone to get a favorable outcome of reducing the particularly more than to reduce the GFR cutoff compared to placebo. We don't have finerenone, yes, has not yet been